Okay, guys, welcome back. This is part 2 of elimination. Here, we're going to focus on urinary. So urinary elimination, that's done by the kidneys, and the kidneys filter blood. They filter toxins, wastes, excess fluids, that type of thing out of the blood, and they make urine. And in a day, a typical adult makes about 1,000 to 2,000 milliliters of urine. It's a lot of urine, okay? So after filtration, the urine passes through ureters into the bladder. And the bladder is just a storage facility. It just holds the urine. Depending on your size, your bladder can hold anywhere from 250 to 450 milliliters of urine. Well, once it gets full, it's going to start to send a message to the brain to say, hey, you have to urinate. Then when we go to the bathroom, the brain actually can relax the internal and external sphincters at the bottom of the bladder where the urethra is, and you pee. Okay. Certain interventions like surgery, immobility, medications, diets can affect urinary elimination, just like with bowel elimination. So what happens? Well, there's something called a urinary diversion. If we have bladder cancer, right, this is the most typical reason, we have to create a diversion to reroute the urine. And it can be temporary or it can be permanent. Oftentimes with bladder cancer, the bladder will have to be removed. And if that's the case, then it's going to be a permanent diversion. Diversion means we're diverting the urine. The kidneys are still there, but they can't send the urine to the bladder because the bladder's not there. So what do? We're going to go over the different types of urinary diversions. They're either continent. That means that the elimination or the release of the urine is conscious or controlled, or incontinent. That means that the urine's just draining out like into a bag or a collection pouch. Okay. So let me show you urinary diversions. This is a nephrostomy. So a nephrostomy is an incontinent urinary diversion. This is the person's back, posterior aspect of the body. Here's the flank area. You're looking at the kidney, and a skinny little tube percutaneously through the skin goes right into the kidney, and the urine will just, as the kidney makes urine, the urine will drain into the bag. Okay, that means it's incontinent. The urine's just draining. Why? There's a problem with the ureter. Maybe there's a blockage. Maybe there's a big stone. Maybe there's hydronephrosis. There are lots of different reasons, okay? The bottom line is that there's a blockage in the ureter, so the kidney will keep on making urine. What we don't want is we don't want the kidney to burst, right? So we have to make sure that the urine's drain out. That's what a nephrostomy is for. So that's one type of diversion. There's something called a coke pouch. It's not a cock pouch. That is a continent ileal bladder conduit. That's a mouthful. It's a continent diversion where the surgeon takes the ileum, part of the small intestine, and creates a reservoir for urine. Okay. And there's an exit on the outside of the body, like a little port kind of thing you can see right there, where the patient would then learn how to straight catheterize themselves every couple of hours and empty the pouch. Okay. So there you go. That's a continent because they have to empty the pouch physically. It doesn't just drain out. And you can see what it looks like inside. There's a little pouch made from a part of the ileum. Okay. Urostomy or a ureterostomy, which is an ileal conduit. These are incontinent diversions where either one or both of the ureters then get diverted and attached to a stoma, part of the intestine, and drain outside of the body. And they would attach an appliance and a pouch on it just as if it were a colostomy or an ileostomy. And you would have an output that's urine because the kidneys are making the urine, going through the ureters and going into that stoma and out into the pouch. This urine is going to be mucousy because there's a certain amount of mucus that's found in the intestine. And because the urine's traveling through that little diversion in the intestine, the urine's going to come out looking a little mucousy. It's normal. All right. So that's a urostomy or a ureterostomy, an ileal conduit. All right. Let's talk about elimination. What does your output depend on? How much are you drinking? How well are your kidneys working? That's something called the GFR, glomerular filtration rate. Okay. Different things drain fluid from your body, like respiration and sweat, perspiration. How much salt are you taking in? And how much fluid are you losing in your poop? So salt, remember this with salt, water follows salt. If you are taking in a lot of salt, you're going to be retaining a lot of fluid. Okay, not healthy, just so you know. Average output for most people is about 1 milliliter per kilogram of weight per hour. Let's put it this way. 30 mils an hour is the bare minimum. Okay, the bare minimum. So 30 milliliters per hour for an adult is the bare minimum. Anything less than that, now you're worried. Okay, you're very concerned. It could be something, kidneys could be failing. All right, then we have issues like edema, which is the retention of fluid, or overhydration, and that's excess fluid that gets trapped in your tissues, or dehydration, which is a deficiency in fluid in your body. So you can have too much fluid or you can have not enough fluid, okay? And it depends on different factors. When we look at urine, what should urine look like? What's normal, okay? Urine should be yellow to amber in color. The clarity should be clear. In other words, you shouldn't see anything floating, sediment or anything like that. It shouldn't smell, or very little, unless you ate asparagus, and then it's going to stink. Urine doesn't smell until it's outside the body and it sits. You ever go to a nursing home and smell that ammonia smell? That's from urine that sits, but urine itself doesn't have an odor till it sits. Specific gravity, that speaks to the concentration of the urine. How thick or how thin is it? Specific gravity is to urine what hematocrit is to blood, right? How thick or how thin is it? So the specific gravity should be 1.005 to 1.03 concentration. And then the pH, somewhere between 5 and 7, a little on the acidic side. Okay. What shouldn't be in your urine? Well, shouldn't have ketones. That's diabetics, right? If you're going into ketoacidosis, you shouldn't have red blood cells. You shouldn't have white blood cells. You should never have protein in your urine. If you have protein in your urine, your blood pressure is probably super high. Okay. Glucose should not be spilling into your urine. Bilirubin should not be in your urine. Casts, which are immature white blood cells, should not be in your urine, and they can also be a precursor to tell you that you may have stones. And crystals should not be in your urine. They can happen from certain drugs, like sulfa drugs. Sulfamethoxazole trimethoprim can cause crystalluria if the patient doesn't drink enough water while they're on it. Fun fact. So here I've included a UA and CNS. UA is a urine analysis. CNS is culture and sensitivity. So let's take a closer look. The urine analysis shows all of those things that I just talked about. The far right is a reference range that tells us what it should be. And then this middle column has the actual results of that urine analysis. Then, if we suspect there's something going on, like a bacterial infection, we take that urine and we send it for a culture and sensitivity. So they put it in a petri dish and they watch it grow 48 to 72 hours. And they're looking to see two things. What do we grow in there? What kind of bacteria? And that's the culture. And the sensitivity is, what is that particular bacterium sensitive to as far as antibiotics? So in other words, here we find that this patient has Escherichia coli, E. coli, in their urine, and they also have Klebsiella pneumoniae. So two different types of bacteria, and a lot of them in their urine. So they have an infection. Then we look here and there's a list of antibiotics. These are kind of like the standard antibiotics, broad spectrum. And there's either going to be an S or an R. Results number 1, that's for the E. coli, and number 2 is for the Klebsiella. So you're looking for an S, not an R, because S means susceptible, R means resistant. I is intermediate. It's usually not that effective. So what you want is, you want to know which bacteria will effectively kill, which antibiotic will effectively kill which bacteria. So for the E. coli, we've got an S for amoxicillin, clavulanic acid, which is augmentin, ampicillin. We've also got Cipro, ertapenem, gentamicin, ipilimumab, levofloxacin, nitrofurantoin, piperacillin, tetracycline, tobramycin, and trimethoprim sulfamethoxazole, right? Any of them that we just named with the S's can kill E. coli. But then let's look at the second column and see what can kill the Klebsiella. A lot of the same ones, right? So what would we wind up going with? I'll tell you, ciprofloxacin is a broad spectrum antibiotic. It is a fluoroquinolone. It's not a sulfa drug. It's well tolerated by most people. The number one side effect is Achilles tendon rupture, which is not common. And so for UTIs that are different types of bacteria, that's the one I would pick to put the patient on. Probably the doctor would pick it too. All right. So that's how we determine what antibiotic to give to someone, right? Urinary elimination problems. Make sure you know what these mean. Urgency. I gotta go. I gotta go now. If I don't get to a bathroom, I'm gonna pee myself, right? Dysuria is painful urination. Oliguria is less than 30 mils per hour versus anuria, which is no urine output. Enuresis is bedwetting. That's the thing. Nocturia is urinating at night. Polyuria, which you guys already learned, is multiple times you're peeing all the time. Incontinence, can't hold your urine. Urinary retention, can't let go of your urine. Can't empty your bladder fully, right? So make sure you understand those terms. Signs and symptoms that you should report. Anybody that's retaining urine after a catheter is removed, and 6 to 8 hours is a long time. We usually will give them 4 to 6 hours tops. So if you've had an indwelling catheter, we take the catheter out, we have to wait for you to pee to make sure that everything's working the way it should. Anybody that dribbles little tiny amounts of urine, or if somebody has a distended bladder following voiding, so you go to the bathroom, but yet the bladder's still distended, means you're not fully emptying, or have a sense of urgency after you voided. That can also be a sign of a UTI. Here's some other words that you need to know. When we talk about a UTI, urinary tract infection, we're talking about cystitis. Cystitis is an infection in the urinary bladder. Okay. Nephritis and pyelonephritis are infection and inflammation in the kidneys. This is one you need to know too. BPH, which is benign prostatic hypertrophy or hyperplasia. Benign means it's not cancerous. Prostatic means of the prostate gland. Hypertrophy, hyperplasia, it's an overgrowth of the prostate gland. You find very often in older men. And when they have that, common complaints would be dribbling, not being able to start a stream, not being able to fully stop the stream of urine. This is something that can become very problematic, and it's very common in older men. Medications can affect how you pee. Diuretics. Here are the drugs that you're going to learn now. You're going to learn about loop diuretics, thiazide diuretics, and potassium-sparing diuretics. Loop diuretics, furosemide and bumetanide. Thiazide diuretics, hydrochlorothiazide, metolazone. And there's only one potassium-sparing that we need to know about, and that's spironolactone. Okay. And we will talk about these a little bit further, but for right now, I just want you to know that these are diuretics. They prevent the reabsorption of water. People call them water pills, which is not something that we should call them because we're nurses, so we call them diuretics. They make you pee. They kick your kidneys into overdrive and make you pee, okay? So obviously diuretics can affect your urinary output. Antihistamines, believe it or not, opioids and anticholinergics can cause urinary retention. It's important to know. Right now, the example I'll give, if you have a gentleman with BPH and they're retaining urine, you'd be cautious giving them an opioid because opioids cause urinary retention, right? Makes sense? And then chemotherapy. Chemotherapy just in and of itself is almost a toxic thing for your body. So it's usually hard on the kidneys. And what else do we need to know? Medications that color urine. Right now, I'm going to give you 3 to get started. Phenazopyridine, which is to manage UTI pain. It's not an antibiotic. It will turn your PP orange or red. Rifampin, indication it's used for TB, and it turns your urine and all of your body fluids red or orange. Saliva, sweat, tears, all those things. So you want to let the patient know about that beforehand because they're going to think they're crying blood like a vampire. And then metronidazole, that's also known as Flagyl. It's an antibiotic often used for C. diff, and that will turn the urine a dark brown or red. So they're the three big ones that discolor your urine. Make sure you know them. Stones, urinary calculi. A calculus, right, or calculi, plural, stones are formed by different substances in the body, usually in the kidney, but they can occur in the bladder, okay? The most common cause of kidney stones or renal calculi are calcium oxalate stones, okay? And it's not calcium, it's calcium oxalate. Caffeine, coffee, dark chocolate, those things and contain calcium oxalate. So if we are able to retrieve a stone that someone has passed, we would send it to the lab and say, what's it made of? So then we can advise the patient things to stay away from so that they don't develop any more stones, because stones hurt bad. And the pain is usually an intermittent and colicky-like pain because the stone forms in the kidney. And while it's in the kidney, it's kind of got room to move around a little bit. When it gets to the renal pelvis, right before it hits the ureter, it's got a good bit of room. But then when it goes into the ureter, as the flow of urine is moving, the stone is moving with the urine. As it moves down the ureter, oh, pain, nothing, pain, nothing, pain. As it moves, the pain comes and goes. When it gets into the bladder, no pain for a little bit because now it's got room. But when they pee, that flow of urine brings the stone with it and it goes through the urethra. Imagine a watermelon going through that tiny little hole. That's what it feels like. So, and we will always give a patient a strainer to strain their urine so that we can get one of those stones and send it to the lab and find out what it's made of. Okay. Then another fun thing that can happen is a cystocele, a bladder prolapse. If the pelvic floor muscles are weak for different reasons, the bladder can fall through the vagina. Men don't have this problem, right? This can happen because of multiple pregnancies and vaginal deliveries. It can happen for other reasons too, but do your Kegels, okay? Kegel exercises. When you're on the toilet and you begin to urinate, when it's going full blast, stop it and then start it. And then stop it and then start it. Those are Kegels. You'll get so good at them that you can do them wherever you are when you're not urinating, and they will tighten those pelvic floor muscles and your bladder won't fall out, hopefully. Question 1. Is the following statement true or false? The nurse should retrieve stones passed by a client during voiding for examination. If you said true, you were right. Yeah. What are they made of? Okay. We already talked about that. Urinary elimination. Let's talk about catheters. So sometimes we need to put a catheter, which is a thin tube, through the urethra into the bladder. Okay. They're usually made of latex, but they can be made of silicone, right? Sometimes we call it a straight catheter or straight cath. That just means intermittent catheterization as opposed to an indwelling catheter, which oftentimes you'll hear called a Foley. A Foley is a brand name. A Foley is an indwelling urinary catheter. And then we have suprapubic catheters, and I'll explain all of these in a moment. Okay, so here's some catheters. This is a three-way cath. It's got the tube. This part goes into the bladder, and see the balloon gets inflated to hold that catheter in the bladder. And then at this end, it's attached to a drainage bag. And then this end would also be attached to some normal saline for irrigation after a transurethral resection of the prostate. We'll talk more about that in med-surg. And then this is just your standard urinary catheter attached to a drainage bag. Okay. And everyone has seen these, I'm sure. If you haven't, then there you go. Most catheters have a straight tip. There is one type that's different. It's called a coude. It's got a curve down at the bottom. Why? If you look at these diagrams here, if a gentleman has a swollen prostate, when you insert the catheter, when you get to that prostate gland, you're going to meet resistance. You may not be able to move any further to get into the bladder. The coude has that curve meant to kind of go under that swelling and up into the bladder, make it a little bit easier to get in. How do you know you're in? Urine comes out of the other end of the tube. Then you know you're in the bladder. Okay, and we're going to talk about the procedure for how to put a Foley in. This is a suprapubic catheter. If someone has an indwelling urinary catheter for a lengthy period of time, the urethra is going to stretch. So they start out with a 14 French, which is a small one. Then it's going to go to a 16 French. At some point, it's going to go to an 18, and then a 20, and then a 22, and a 24, which is basically a garden hose. So when it gets to that point where we are at the largest size and it's still leaking around it, then we're going to do a suprapubic catheter, which is where we go directly through transcutaneous, through the skin, into the bladder. Same principle, same type of catheter. Goes in, and the little balloon holds it in place, and it drains into a drainage collection device, whether it's a bag, right, or whatever. So that is a suprapubic catheter. Caring for the catheter. The bag needs to be below the bladder, but never on the floor. Never on the floor, right? Always make sure that it's patent. The word patent means it's draining, right? So the flow of urine through the tubing, that's called patency. I'm going to put that there because you need to know that word, okay? You're always going to measure how much urine goes out, right? Empty the bag regularly. Sometimes you may have to irrigate the catheter to make sure it maintains its patency. And then there's an external catheter called a condom cath, obviously for men. It goes on the penis like a condom, right? And then it can hook up to a drainage device like a bag. Problem, they don't stay on. They really don't stay on. Sometimes they do, but they're not very successful. But these are a nice alternative because if someone's incontinent, that is not a reason to catheterize them. Incontinence is not a reason for catheterization, okay? So for a male client, you could try the condom cath, an external catheter, or just put a brief on them. Female client, perineal pad, disposable incontinent brief, or something called Pure Wick. And then there's bladder retraining and self-catheterization. In med-surg, we'll get into more detail, okay? So this is enough, but I do want you to know about the condom caths and make sure you know that incontinence is not a reason for an indwelling catheter. No, no, no. This is a Pure Wick system. These are relatively new, past like 7, 8 years, I think. This blue piece right here, blue and white piece, just sits over like in the labia, in the middle of the perineal area, and it gently draws the urine out through this tubing and into a collection container. Okay, so very expensive, very expensive. Urinary retention. After anesthesia, most common reason, because of the opioids, right? They're going to retain urine, maybe. So we want to make sure that we're checking to make sure their bladder's not distended, make sure that they're urinating, and make sure that they're not uncomfortable, right? If necessary, they would be catheterized. That should be the last resort. We don't go right to that. Bladder scanning. That's something that's done now. You have a little ultrasound machine, a bedside sonography machine. So you just go to the patient. It's not invasive. It doesn't hurt. You don't need informed consent for it. And they just take the Doppler with some gel and run it over where the bladder is, right at the pubis symphysis. And they can see, give or take, how much volume, how much urine is still in your bladder after you peed. And that'll tell us if you're retaining urine. If you have over 100 mils in your bladder after you've urinated, you're probably going to need a catheter. Okay. Anything less than 50 residual still in the bladder after you pee, that's normal. Okay. So make sure that you know over 100 is going to need an intervention. All right. Other diagnostics you should be aware of: a KUB, kidneys, ureters, bladder. It's just an X-ray. And it's just looking at the size, shape, and structure of those organs. An IVP, an intravenous pyelogram. That's where we put contrast dye so that we can look at the ducts, the renal pelvis, the ureters, the bladder, and the urethra. If the patient is allergic to shellfish or iodine, they cannot have this contrast dye, okay? And then last but not least, a renal scan, which is a view of renal blood flow and anatomy of the kidneys without contrast dye. So if they're allergic, then they would probably have that done. Okay. We can also do a renal ultrasound. Again, that's just an ultrasound to try to look at the gross anatomy. It's not really going to give us a lot of information. It may show a lesion or something abnormal that we would want to follow up on. And then what's always fun is a cystoscopy. Whenever you see oscopy at the end, scope, It's where we take a catheter with a light inside of it and a camera, go through the urethra, and we can look inside the bladder and the urethra, and maybe even get a specimen if we need a biopsy, if we suspect cancer, or if we just want to see what's happening in there because maybe the patient's been having chronic issues. Okay. All right. And then for catheter insertion, you need to know this, and we will go over it in the lab, but 8 to 10 French is for kids, 14 to 16 for females, 16 to 18 for males, and maybe they go as high as a 24 French, okay, which is pretty big. If they're allergic to latex, you can use a silicone product, okay? And every hospital, every facility should have them. And there's catheterization kits where everything's right there in the kit, handy dandy, nice and neat and sterile. It's a sterile procedure. Urinary catheterization is a sterile procedure. Okay, make sure you remember that. Sterile, sterile, sterile. The next few pages give you the details, step by step, of how to insert a urinary catheter. I am not going to read this to you, but I want you to read it and make sure that you understand the steps. Okay, see where I have this highlighted? This is important because if it's a female, sometimes it's a little hard to find the urethra. Female anatomy, you've got the clitoris, the urethra, the vagina, and then the anus. Okay. Ask the patient to bear down like they're having a bowel movement. That helps push the urinary meatus out a little bit so it's easier to visualize. Okay. Make sure you know that. Okay. And this is the rest of it, how to insert a catheter. Make sure you read through that. Is the following statement true or false? It is necessary to reduce the intake of fluids for somebody who's incontinent. You better have said false. Never, ever do that just because they're incontinent, for the love of God. Okay? They gave them a UTI. We're just going to have to figure out what to do or clean them up more frequently. Okay? Do the right thing. And then the end of this talks about nausea, vomiting. Okay? Nausea is the feeling of being sick and you feel like you might vomit. Vomiting is also called emesis. It's involuntary, where your stomach contents get expelled, sometimes forcefully, like The Exorcist, which is projectile vomiting. And you see, I have this highlighted. Emesis that resembles coffee grounds is an indicator of a GI bleed. And oh, by the way, measure it because emesis counts for output. I hope this was as fun for you as it was for me. So that's all we got for now. Until next time, see ya.